Okay, everybody, if you could please turn your cameras on. Okay, and you will get your scores hopefully tomorrow. It sounds like everybody should be done by tomorrow. Like I said, we can't really talk about it because there's even some people in here that weren't able to get in. So they'll be testing right after class, okay? Any questions on chapter 6, 7, or 8 that you guys have? No? Okay, oh, looks like some more students. Okay. All right, as long as there aren't any questions, we are going to go through just a brief review today of chapter 6, 7, and 8. And then I will be sending out videos for the remaining chapters. We don't have class next week, so it's Memorial Day. Take the day off. But your worksheets will be due on Tuesday, and I will be sending out videos. Okay? So please do review those. All right. Let's start first by reviewing. I'm going to break you guys into some groups, and we're going to do the Google Doc thing. If one person could please just be sure that they can share their screen and you guys can work together, okay? And let me see here. You will have to download the worksheet because it's one worksheet that everybody will be using, okay? Or you can just copy and paste it, whichever works easier for you. Okay, here we go. Now let's break you guys up into, let's see here, how many people do we have here? Three, 4, 5, 25. Six, 27. So we'll do 9 groups here. Okay, but before I do that, here's the link to the worksheet. Oh, let me just make sure I got the right one here. Yep. There's your link. And then here are your rooms. And then I'll be joining you in your rooms, okay? Oh, group 1. Can you, let me share my screen. Okay. Share screen. Here we go. All right, can everybody see that? Can I get some? Okay, thank you. All right, so group number 1, what did you guys put for this first one?
So that was the unusual step.
Okay. So, and how did you guys go ahead and you can annotate this by clicking where it says more options or options, and show us how you came up to that, how you came to that conclusion.
basically the mandibular molars are situated more mesially than
Okay,
maxillary counterparts.
very good. So you're always looking at the mandible. And do you see how it comes down like that, everybody? Should have chosen, let's see if I can get a different color here. Okay, so the mandibular is mesial. Okay, does everybody see that? If you have a question, please let me know. All right, group 2, how about B?
We wrote that it was flush terminal plane.
That is correct. It is a flush terminal plane. Okay, so here we have mesial step. Here we have flush terminal plane. And then group 3, what did you see with B? Or excuse me, C.
We wrote that that's a distal step because the mandibular molars are distal to the maxillary.
Very good, very good. So they are seeing, oh, it's not letting me have my pen. Okay, so they are going here to back and down, right? Everybody agree? Okay, so go ahead and tell me if this was permanent teeth, how would we describe it? Unit or group 4, how would you describe, what would a mesial step look like?
Wait, who's group 4?
Group 4 is group 4 is Dominic, Journey, and Sarah.
Can you repeat the question, please?
So how would you describe the mesial step in the permanent dentition? Which teeth are going to be lined up and how? So we go by which, go ahead.
I was just gonna say the mandibular molars and the maxillary counterparts, or like the maxillary molars.
So the mandibular first molar.
Okay.
Is what? We always go by the first molar. Is it going to be mesial or, oh, very good. Mesial to the maxillary first molar. Okay, so the maxillary first molar, how is it going to sit on the mandibular first molar?
Is it gonna be distal then to the?
So it's going to be a little bit distal. How do we want it to line up to the mandibular buccal groove? Okay, so the maxillary first molar is gonna, the mesial, so first molar, mesial buccal cusp tip is gonna lie in the mandibular molar buccal groove.
Okay.
Okay, so here are okay, so these are our permanent molars right here, right? So this mesial groove or mesial cusp tip here is lying in this buccal groove. And that's what a mesial, that's ideal. That's going to be our class 1 occlusion.
Okay.
And that's what we want our occlusion to be, is a class 1 occlusion. Okay, so that is associated with a mesial step. Okay, so then if we're talking about our permanent group 5, generally we aren't going to see a terminal flush plane. We aren't going to worry about that. But what class, I got to erase all this. Everybody got that? I got to erase all that. Okay. Now, group 5. What about the distal step and the permanent dentition? What occlusal classification is that usually associated with?
Would it
be class 3?
3?
It's actually going to be class 2. Okay. So what's happening is class 2, they're going to have a retrognathic profile. Do you guys remember that from the video? Where the jaw is going backwards. So you think of that mandible, that first molar is going to move back, going to move distal. Does that
So
make
it's more like an overbite.
Yes. Yep. Okay, so this equals class equals distal step. Now, a mesial step is also associated with class 3, and we'll get into that a little bit later, okay? So a distal step is associated with occlusal class 2. Now, there are 2 types, 2 divisions of class 2, right? Anybody remember that? Division 1 versus Division 2. If you don't know, follow along in your book, okay? So Division 1 is going to be what? It has to do with the central incisors.
Is that when the incisors are normal?
Yep, normal, or they could be jetting out. Very good. Hated or jetting out. Okay, it could be either. And then what about Division 2 of class 2?
Overbite?
Could be overbite, but how are they positioned?
Don't they dip?
Okay, yep, they go backwards, right? They're retruding. How many of you guys have seen that, where somebody's lateral incisors are sticking out farther than their central incisors? It's pretty common.
Yep.
Yeah, I see Samantha shaking her head. Yep. Diamond's shaking hers. Very good. Okay, so which occlusal class is a class or classes are associated with a mesial step? Jessica.
I'm sorry, can you repeat that?
Which occlusal classes are associated with a mesial step?
I don't know.
Okay, anybody want to help her out?
Class 1?
Class 3.
Class 1 and class 3. Very good. Okay, and then class 2 is associated with a distal step. So if I take my guy here, all right, I gotta take these guys off. Okay, I have this guy here, and we are going by the first molars. Okay, these are the first molars. This is a class 1. Do you see how that mesial buccal cusp of the maxilla is lined up in the buccal groove of the mandible? Okay, everybody see that? Always going by the first molars. Now, if I were to go to a class 3, that means that this jaw is projected forward. Do you see? There we go. I'm sorry, that's a class 2. Class 3. Here's our class 3. Do you see how there's still a mesial step there with the mandible?
Yes.
Danielle, how are you doing? You good? You just give me a thumbs. You're silenced. So
I said I'm good. It just
Okay.
looks painful.
it's just the way their jaw grows. It's not painful. Okay. Chelsea, how are you doing? Okay. All right. So that's a 3. Where so do you see how in both of them there's a mesial step, just one is more exaggerated than the other?
Mm-hmm.
Okay. And then a class 2 is like this. Do you see how now that's a distal step?
Yep. Mm-hmm.
Is that helping you guys? Okay. Gotta look at my second screen, see everybody's faces. Shay, how are you doing with this? Good. Madison, you're doing okay? All right. All right. So those are our steps. Okay. And our occlusal classifications. Now, share my next screen with you guys. All right. Now let's move on here. And this is figure 6.6 in your book, if you guys want to take a peek at it. All right. And which of these, here we go, this is 6.6 here. Which of these would be protrusion? And which one would be retrusion?
A would be protrusion.
A would be protrusion. Very good. Okay. And why, who said that? Shay, was that you? No.
Zoe.
Zoe, could you tell us what is it about A that tells you it's protrusion?
Because of a lack of labial support from an upper lip that is too short.
Okay. So, but this is, let me, okay. This is jetting, not writing, sorry. I am sharing the screen. You guys can see A and B here, right?
Mm-hmm.
Why is it not letting me annotate? All right, we're just going to use the spotlight then. Okay, so this here is jetting out. So now we're looking at the maxillary. When we're looking at overjet, overbite, we're looking at the maxillary. When we're talking about occlusion, we're looking at the molars. So here, this tooth is jetting out of the mouth, right? So that is protrusion. Does that make sense to everybody?
Yes.
All right. And then here, it's kind of hard to tell, but this is going to be our retrusion. See how this tooth is going in, and I can't, well, maybe I can't, oh, I can scroll up. This is a little closer, but what you're seeing here is that the lip is coming in between there. Okay. So here they're both jetting out. Here they're coming in, and it looks different because the maxillary teeth are situated a little bit different, how they lie in the mouth, so it's harder to tell here. But this is going to be retrusion, moving backwards. Okay. Now, if you look at 6.7, let me get my book here. Does everybody have their book up? Silence. I had mine up. If you look at figure 6.7 and A and B, what do you see?
6.7.
Yep.
That the cusps on A are kind of interlocking together, and then the cusps on B are just kind of sitting on top of each other.
Very good. Okay, so what does that mean? Which one is ideal?
A.
Everybody agree? Disagree?
Yeah, A.
Okay, A is preferable. Okay, so I have it here. So we want our cusp to interlock, as what was said, right? Why would B be a bad thing?
Over
Because you
time,
could-
the cusps wear down.
Yes, the cusps are going to wear down very quickly. Very good, Samantha. So we want that interlocking. Okay. Oftentimes people think that this is the perfect smile, right? That your edges should meet. But that's not the case. And why is that not, Samantha? She's on top of it today. Why would that be? Why do we not want that? Lindsay, why do we not want our incisal edges right on top of each other like this?
That's creating too much force. They're gonna start to wear down.
They are, yes. They're going to wear down, and as the person chews, sorry, like I said, I'm not good at selfies. As they chew, they're going to completely wear down. How many people have seen individuals that their teeth are really worn down?
Oh,
Yeah.
Yeah? And it gives them an older look, doesn't it?
Mhm.
It's because that bite is collapsing from all of the wear. All right? They're losing that vertical dimension. All right? Very good, you guys. So you want that intercuspal relationship where food can really grind in there, right? Our molars are grinding food. Very good, you guys. All right. Can you guys tell me, let's see here, I'm going to start with Sarah Olson. Tell me what centric occlusion is. You can use your book. And then Summer, are you there, Summer? Summer's like, I thought I got away for a second. Can you tell me what centric relation is? Because there's a difference. I really want to make sure that you guys understand the difference between these two and why it matters.
Can you say one more time what it is? Centric what?
Centric relation is the one that you have.
Okay.
Should I explain it right now?
Yes, please.
Okay. So centric occlusion deals with the teeth. It does not have anything to do with the bones or muscles of it. And it's kind of just like how the teeth fit together when the jaw is closed.
Okay, so that's centric occlusion is when you put your tongue, everybody put your tongue to the back of your mouth, like this, all right? And bite down. Okay, that is your centric occlusion. All right, that is your occlusion. Summer, do you have centric relation yet?
So, I kind of looked it up and it said the mandibular jaw position in which the head of the condyle is stimulated as far as the anterior and superior.
Okay, so centric relation has to do with the bone and the muscles, and centric occlusion has to do with the teeth. Now, this is probably the only time you guys are ever going to need to know this, but we do need to know what each is so that when we're reading articles in the future that you know what centric occlusion is and what centric relation is, okay? So when we look at the worksheet that I have here, our centric occlusion is how our cusps are coming together. And these are the ideal contact points, and you don't have to memorize this. But do you see that it isn't right on top of each other? We're touching in different parts of all of the teeth, okay? So why do you think, well, I already told you why this matters. All right. And then, let's see here, Stephanie, can you tell me how I would get, with this, how I would get a class 2 occlusion?
To class 2.
Yes.
So that's where the central incisors are jutting out. So you just move the maxilla forward.
Okay. So they aren't always jutting out, but they can be. This is a class 2. And now if it was class 2 division 2, let's see here, Chelsea, what would these central incisors be doing?
I'm not quite sure.
Class 2 division 2. Diamond, do you know what would be, how we would get a division 2 here?
Can you guys hear me?
Yep.
Okay, so
Cute kids, by the way.
thank you. Oh my goodness. Okay, so class 2, you said division 2?
Yep. So what's going to be the difference here?
Oh, the mandibular central incisors would be faced lingually, right? No, I'm sorry, the maxillary.
Maxillary. So these two teeth here are going to tip in. So they would go in like this. They would be retruded.
Yes. Yep. They would be.
Okay.
So if I said that they were inclined lingually, would that be correct?
Yeah. Yes, they would be inclined lingually.
Okay.
Okay, so they'd be tipping this way. You see how they're all going like this?
Yes.
Those central incisors would go like this now.
Yep.
They're going in this direction.
Absolutely. Yep.
Okay. Let's see here. Brittany, can you please tell me what I would have to do with this to make it a class 3 occlusion?
The mandible is more forward.
Yes, it's the Jay Leno look, right?
Yep.
There we go. Okay. So that's going to be our class 3. Still has a mesial step, but this is now a class 3. This is not ideal. What do you guys notice about the anterior teeth when I do a class 3?
Has a crossbite?
It has a crossbite. What does a crossbite mean?
Where some of the mandibular teeth are outside of the maxillary?
Very good. Very good. That is a definite concern and a referral to the orthodontist. Okay? So, class 1, class 2, and class 3. And this has what we call an anterior crossbite because these mandibular teeth are outside of the maxillary teeth. You can also get crossbites in the posterior. Do you see that? Okay. And that's usually if this jaw doesn't spread far enough. Okay. Oftentimes that can be unilateral or bilateral, but often I just see it on one side where the jaw just didn't spread properly during its growth. Okay.
So,
Can
Yes.
you have completely functional class 2 or 3 occlusion, or are you just always kind of aiming for a class 1?
You're always aiming for a class 1. Like if you were to go to the orthodontist, that's what they want.
And is the primary concern if you have, like, say, for example, a class 2, that your third molars aren't being used when you're chewing, or?
No, it is more under stimulation. So it's actually more under stimulation of the gingiva and the anterior, so it can lead to a lot of periodontal problems. It may indicate that there is problems with our centric relation, meaning they could have problems with their TMJ, their temporal mandibular joint. Okay. So it all kind of depends on what the cause is of it. Good question, Dominic.
That was me.
That was Neil.
Oh, Neil, sorry. Dominic had the yellow highlight around him, so.
Well, I was about to start talking, but then he started talking.
Oh, okay. What were you going to ask, Dominic?
Never mind.
Okay. So what would an overjet be? Let's see here. We are going to go to Nicole. What would happen to this to get an overjet?
Is that when the front teeth are jetting outward?
Very good. So would that be horizontal
Yes.
or lateral?
Horizontal.
Horizontal, because they're moving horizontally. Does everybody get that? And then overbite would be when these centrals are going to be, when they close together, this incisal edge is going to be all the way down here. Okay? And they can call that a deep bite. And I can't do that with this, I don't think. Okay, there we go. Whoop. Kind of kitty wampus. All right, it would be like that. Okay, everybody get that?
Sorry, can you explain overjet again?
Overjet would be when these teeth are jetting out. So if you're looking at their profile like this, these front teeth would be going out like this. And often caused by what?
Sucking. Thumb sucking?
Thumb sucking, but usually it's from the muscles of the tongue pushing up against it. Thumb sucking, you'll see more of what we call an open bite.
Open bite. Can it also be from like pulling? Because I know some babies, they pull, they have a blank and they
pull on it. So that brings us to the next thing, open bite. Open bite is when all the back teeth are occluding, but the anterior teeth are still open. So imagine all of these are touching in the back, but it still looks like that in the front. And that's often associated with thumb sucking. Has anybody ever seen that? Yeah, it's really unfortunate. So that's called a parafunctional habit, when it's due to a habit that the patient has. Okay.
I have a question.
Mm-hmm.
Would class 3 ever be considered like, or could you ever consider it to be like a nerve bite, or is it always just going to be a class bite?
You know, your audio is kind of poor. Can you say that again?
I said, could you ever consider class 3 an underbite, or is it always going to crossbite?
Well, so they can have a class 3 sometimes if it's just, it would never be, I shouldn't say never, but it could be if their maxilla is more long, I guess, and their jaw is still protruded forward. Usually it's going to be end to end or underbite. End to end meaning the incisal edges are right on top of each other. Excuse me, that's edge to edge, and the posterior would be end to end. Does that make sense? It's really hard to get a maxilla that's big enough when the mandible, like it's possible if it's long and narrow, but I would not say it's associated with it at all. It's usually going to be an underbite or edge to edge.
Okay.
Okay. I've seen some really weird bites, so I've seen about everything. So when you're in clinic, so you'll have to take everybody's bite. You'll have to classify each of your patient's bite. The first thing you're going to look at is the first molars, right? What if they're missing a tooth in front of that? Say they're missing a premolar. Then what do we do? Can we still do their bite?
You look at the canine.
We'll go to the canines. Yep. Okay. So if they're missing a tooth, we don't do the molars. We'll then do the canines. All right. So you're going to look at the molar relationship, and if you see a 3, your eyes are immediately going to look for cross bites in the anterior or edge to edge. Okay. Does that answer your question, Dominic? Kind of. All right, and then if you see a class 2, then you're going to look to the anterior and look for overjet and retrusion, right? Okay. So what factors do you guys think affect tooth alignment before the age of 5?
If they're missing any of their deciduous teeth.
Very good. So that's 1. Because if they didn't develop a deciduous tooth, then we know that they aren't going to develop a permanent tooth. Okay. What's another one?
Delayed exfoliation of the deciduous teeth, or
Yep. If they lost the tooth early, right? Yep. Very good. What else?
Primitive space.
The primitive space. Very good. What else is going to affect it? Think of those parafunctional habits. What did we just talk about?
Thrusting and
tongue thrusting and thumb sucking. How about extended pacifier if they have a nook or a pacifier for a long period of time?
Now, I was wondering about that one because I didn't see it in the book. How does that one,
It does still affect it if it's extended, if it's, beyond probably 3 years of age. So they get an open bite from sucking on their thumb because their thumb is in their mouth so much that their back teeth begin to touch, but it prevents the anterior teeth from coming together because their thumb is in their mouth so much. Does that help you guys remember now? Open bite. It's just because it's in there for so long that the back teeth start to occlude, but the front teeth don't. All right. Very good, you guys. Let's see here. We have 1 hour. feel like you guys have a pretty good grasp on this. You know, watch the video if you have any further questions. Let's see here. We talked about overbite, underbite. Talked about parafunctional habits. All right. So overjet, overbite, crossbite, and open bite are all types of malocclusion. All right. Mal meaning bad occlusion. What are some oral or other health problems that can result from malocclusion? So now they have overbite, they have overjet, crossbite, open bite. What is the problem? Why is this a problem?
I know someone that has a class 3 and he has really bad problems with sleep apnea.
Interesting. Okay, so mouth breathing, they could be a mouth breather. What else, you guys?
They might have a really hard time reaching certain parts of their teeth or their mouth to clean them.
Very good. So perio and decay issues. What else?
So to stem off like what she just said, like would you have like gum issues then too?
Absolutely, because we're going to have under and overstimulation of the gingiva.
Okay.
What else?
Can affect speech.
Speech, very good. Very good.
What about TMJ? Would that happen?
Absolutely, that can happen. Doesn't mean it's going to, but it could. Yep. Because of that centric relation. Okay. What about eating? Do you think we might see some malnutrition?
Yes.
In some of these patients, right? Eating and chewing difficulty. We might see accidental biting of the cheek or accidental biting of the lip, cracked teeth, right? And then aesthetic concerns, right? All right, very good, you guys.
Can I ask a question about cheek biting?
Mm-hmm.
So, when you have a patient that comes in and you can see that there's that, white line on, the buccal mucosa that indicates that they've been cheek biting, unless it's really like biting into the muscle or like causing them to like break the skin, is there really a problem that comes with cheek biting?
So that's actually, it's called linea alba, okay? And that is actually due to clenching and grinding at night. The linea alba is. And something you guys will learn a bit about, especially when you're in clinic, because Lindsay, you are going to see that a lot. The linea alba. When you see pronounced linea alba, like it's really sticking out, what you're going to then look for is the tongue. Because if they're clenching and grinding, you're going to see linea alba, and then the tongue is going to be scalloped on the sides. Okay? And those are classic signs of clenching and grinding. So then what might we see on the teeth?
Wear facets.
Wear facets. Very good. Yep. So biting the cheek and stuff, you're going to see more red, like bruising on there. Okay? Red or purplish lesions there. But the linea alba is usually due to clenching and grinding. And again, then you look for, so it's like keying in on all these signs. Oh, that's a sign of clenching and grinding. Let me look for wear facets. Let me see if their tongue is scalloped. All right. So kind of starting to put, that's good critical thinking already, you guys. You're doing great. All right. Should we take a 5-minute break and come back and we'll go over chapter 7 and 8. Okay. So come back at 11 o'clock. All right, everybody, if you could turn your videos back on. Okay, so what we're going to do next is you guys are going to go back into your Google Doc and you are going to work on questions 2 and 3, okay? So I'm going to put you back in your breakout rooms. It's the same Google Doc. Does everybody still have that link? Okay, so look in chat for it. Okay. All right, and I will put you in your breakout rooms again. Open them up. There you go. Okay, it looks like everybody's back. So, group 9. Let's see here. That would be Heidi and Nicole. Can you guys please give us some information off of question 1?
Yeah,
Or excuse me, question 2, but.
Let me go back there, sorry.
So it would be examples of supernumerary teeth and congenitally missing teeth. Why don't you do those 2?
So for supernumerary, we did mesiodents and paramolars.
Okay.
And then for the congenitally missing teeth, we did, we just put the third molars, the maxillary, and mandibular are the most common ones that are missing.
Okay. And did anybody get other answers?
We had maxillary lateral incisors.
Okay, great. Anybody else have another answer?
First premolar.
Maxillary or mandibular?
Mandibular.
Yeah. Okay. So which one is the most likely? Let's put these in order of the most likely to least likely. So third molars, are they more likely or less likely than the other 2 groups?
More likely.
More likely. They are the most commonly congenitally missing teeth. All right. Then when we talk about the laterals versus the premolars, maxillary laterals versus mandibular premolars, which one is going to be more likely?
Lateral.
The laterals. Yep. So third molars, laterals, premolars. Okay. And then when we talk about supernumerary teeth, that means extra teeth, right? And what is going to be our most commonly common supernumerary teeth? It's actually the distomolars or distodens. Okay, which is additional third molars. Okay, so it goes third molars, so distodens, distomolars. Then it goes mesodens, which is an additional central incisor, and then paramolars. Okay. Group 8, microdontia and discolored enamel.
So we said that for the microdontia, there would be like peg laterals.
Very good.
Or your maxillary central incisors would be another common one.
Okay. Also third molars. You can get pegged third molars also. Okay.
Discolored enamel was the second one?
Yes.
We said the dental fluorosis.
Okay.
Would change them, color, and we'll mottled enamel.
Yep, that is from fluoride, right? Okay, anybody else? Any other groups have?
We said tetracycline staining.
Very good. Okay, what else for discolored enamel?
Ameliogenesis imperfecta.
Very good. Anybody else?
We mentioned dentin genesis imperfecta.
Right, because if that dentin isn't there, that's going to change the color of the enamel, right? Very good, you guys. Okay, group 7, extrinsic and intrinsic factors. Can we first, before that, let's talk a little bit about extrinsic and intrinsic factors. What is an extrinsic factor? Neil.
It's a factor from outside the body.
Factor from outside the body. Okay. And then intrinsic, Taylor?
The factor from inside the body then?
Very good. Okay, so group, what are we on, 7? Group 7, please give us some examples of factors causing anomalies that come from outside the body. Group 7 is Brittany, Chelsea, and Diamond.
I said that for extrinsic factors, so like the fluorescein and then would tetracycline stain
Yes, tetracycline and fluoride. Anybody put anything else?
We had beta blockers as far as medication goes. High blood pressure medication, which gives you dry mouth, thus causing a lack of saliva, which means a lack of tooth nutrition.
Right. So, but that wouldn't be, that's really forward thinking, but that wouldn't cause an anomaly. That could cause like decay and contribute to periodontal disease and stuff like that. So good thinking. I like the way you guys are investigating things, but that's not quite an anomaly. So this would be, you guys will find out next semester, pregnancy category X. So generally you aren't going to want to give medications, but how about trauma, right? Did anybody put trauma down?
Chemical trauma.
Chemical trauma, even physical trauma, falling before the tooth is erupted. If they get an abscess in there, that can cause the developmental anomalies also. Okay. Group 7, intrinsic factors.
We didn't know if this would work, but we were talking about like acid reflux.
Okay. That wouldn't cause an anomaly, but it would definitely change the enamel once they're erupted.
Congenital, so like congenital syphilis. That
Very good. Okay.
Okay.
Anybody else?
Enamel hypocalcification.
Okay. Very good. All right. Very good, you guys. And then what are a couple examples, group 6, of related to congenital syphilis and abnormal root formation? Group 6 is Esther, Shay, and Taylor.
Just roots, or can we say like crown anomalies as well?
Root anomalies for just in general, root anomalies.
Okay.
Hutchinson's was the one with syphilis.
Hutchinson's incisors. They look a little bit like flathead screwdrivers. Okay, what's the other one?
Mulberry molar.
Mulberry molars, where it looks like a mulberry or a blackberry almost on top. Okay, so what are some abnormal root formation? Root formations.
Dilacerated tooth.
Dilacerated roots, okay, where they're bent at 40 degrees or greater. What are some others?
Flexion.
Flexion. And what is the difference between flexion and dilacerated roots?
Flexion is, oh, well, I was just going to say flexion is like root only, right?
It is root only, and it doesn't have to be quite 40 degrees. So what is the problem if somebody has these bent roots?
Root canal.
Extractions and root canals, exactly. So for the most part, it's not going to be a problem. But when we get to any periodontal problems or anything like that, or decay, if they need the tooth taken out or if they need a root canal, that can be a problem, okay? A root canal can't be done usually. They may do a root canal and then just cut off that part, go in surgically and cut off that part of the root. Extraction, they would have to drill out more bone to get to it, so it would be longer healing. Okay. What about cementum? Can anybody tell me if they came across anything with cementum related to the roots?
Hypercementosis.
Hypercementosis. Very good. And what causes hypercementosis?
It's just excess cementum built up around the roots.
Right. Caused from trauma a lot of times. Okay. So also cementoma. Can you guys differentiate between gemination and fusion?
Isn't it fusion when two roots just fuse together as one?
Okay, where do they fuse at? The cementum or the dentin, enamel? Where do they fuse at?
The dentin.
The dentin?
Okay, what is fusion with cementum? Or what is it termed when they're together with cementum?
That's concrescence, right?
Concrescence can be part of it, yep. Can be one way. All right. What's the difference between fusion and twinning?
Well, would it be like when two teeth like come together, but the twinning is just like when one tooth.
So your audio, I'm not sure. We can't really understand what you're saying. Your audio's kind of poor. Sorry, Dominic.
Okay, yeah, just cut out. I don't know if you
Can somebody else address what the difference between twinning and fusion?
So it says that twinning is when a single tooth germ splits. So
okay,
two identical like teeth.
Yep. So it's kind of like having twins, right? One germ, one embryo splits. Okay. Where fusion is what?
The two fuse together, two different germs fuse together to make one.
Correct. Okay, so it's like fraternal twins and or what do they call them? What are the two different? We have identical twins and then we have fraternal, right? And fraternal is two embryos from the start. And then identical twins, it's one embryo that then splits, right? So this is the same thing. We have one tooth bud turning into two. That is twinning. They're still fused together. Okay. And then fusion is two tooth germs that just happen to combine. Okay. Everybody good? And gemination has two crowns and one root. Okay. All right. Let's see here. Make sure I cover everything here. Okay. So how do we prevent extrinsic causes? How can we prevent some of the extrinsic causes of tooth anomalies. If you have a pregnant woman that comes into your office, what are you going to tell her?
Avoid taking unnecessary medications.
Very good.
Especially the ones that have tetracycline in them.
Mm-hmm.
And cause staining.
Yeah. So to let their physician know, right, that they're pregnant. Okay. You know, and then if there's any trauma during that time, if she has a fever, to make sure it's controlled, because fevers can cause a lot of problems with enamel development. Okay. So workplace safety, anything like that, just to make sure that they're nice and safe and getting the nutrients that they need. Okay. I think that's that for chapter 7. Now let's move to our worksheet. The next part, chapter 8, we're going to go through the parts of the gingiva. And group 5, can you share your screen? So group 5 is Neil, Paku, and Kate.
Yeah, I don't think we physically labeled them, but we do know
That's
what
fine.
individual.
Okay. That's okay. Go ahead and share your screen. And
I could, if you pull up the image, I could annotate.
Oh, there you go.
That works too.
There we go. Okay, so show us where the free gingiva is.
Free gingiva.
So you can use, it says view options up above. You can use annotate. And you can just click on the arrow and then put the arrow on there.
Where
there's a green at the very top. There's a green stripe and then view options.
Okay. The free gingiva would be like from this area.
Okay. Very good. So it just goes around. It just goes, I can't highlight. All right, so it's this collar of tissue right here, right? And does anybody know what the typical length of that is? Or depth of it, I should say?
0.5 and 2 millimeters.
Yep, 0.5 to 2 millimeters, very good. Okay, and then where's our alveolar mucosa?
It's down near the bottom, right?
Down here.
Right,
yeah.
That's that loose mucosa that's really red because it's thin, right, you guys? And then alveolar bone, you can't really see that here. Where's our attached gingiva?
In this area.
Very good. That is our attached gingiva. All right. Periodontal ligament, where would that be located? It's not really on here, but where would you find the periodontal ligament?
Wouldn't it be in the attached unit?
Yes. Yep. Okay. So let's go ahead. I'm going to stop the sharing here. And we're going to go to mine. Here we go. And you guys go ahead and go to your annotate on top, that red area. Can you all see my screen? Yes? No? Yeah, okay. All right. So, group 4, Sarah Olson, can you please highlight or point out where the periodontal ligament is? It's labeled here for you.
Sorry, I thought I was not on mute, but I was on mute. So it'll be like this blue stuff. all the way around?
Very good. Very good. Okay, so those are the ligaments holding the tooth, the cementum. They're embedded in the cementum and into the bone. Do you all see that? So what are, let's see here. Samantha Olson, could you please type in, go under annotate, and then T where it has text, and tell us what the 3 parts of there are of the attachment unit. There you go. And then Maddie, if you could identify the bone, and Jessica, if you could just highlight the different fibers.
What do you mean by highlight the different fibers? Like the names of them, or?
Yep.
Okay.
Thank you. So the 3 parts of the attachment unit are the periodontal ligament, the alveolus or the bone, right? And the attached gingiva.
Is excuse me, is the cementum part of the attachment unit?
Yes. Yep. So it's where the 2, so we think of the periodontal ligament, and then what's it attached to? It's attached to the bone and to the cementum, right, everybody?
So then I've mistyped and I wrote attached gingiva and I can't delete it.
Oh, okay.
So instead of that, I'd like to say cementum.
Okay. I think there. How's that? Can everybody see mine? And cementum.
Thank you.
Yep. Okay, so look at all these fibers that we have here. We have our alveolar crest fibers, and these fibers are going to be near the crest of the bone. Okay. Then as we move down, we have horizontal fibers. So these are fibers situated horizontally. Then we have our oblique fibers, and these fibers are a little further down. Diagonally. Sorry, I spelled that wrong. I'm not going to go back and get it. And then our apical fibers are our fibers found at the apex. Okay?
Wait, don't delete it yet. Let me.
Okay. Thank you for speaking up.
Okay.
Okay. Now, if we go down here, we're going to see a few more fibers. Let me see if I can get both of these on here. Okay. All right. So here, you're going to see these transeptal fibers. And transeptal goes across the septum. All right, this is our septum of bone, just like you have the septum on your nose. We have the transeptal fibers, and they're connecting these connect the cementum of 2 teeth. So these are not embedded in bone. Does that make sense? Then we have our intraradicular fibers. And our intraradicular fibers connect the cementum of the furcation areas to the bone. Okay, does that make sense to everybody? All right. One more that I want to add to this that I think are our horizontal fibers. Can anybody tell me, or not our, oops, hold on. Okay, let me grab a picture here. I'm just going to share my book. Okay, can you guys all see that? Yeah, okay. Thank you for those of you who shake your head, yes. Let's see here. It's up a little bit further. Right here. Okay, these are our circular fibers. Right here. Okay, and what you need to know about circular fibers is that they don't embed in the bone or the cementum. Okay, they are found in the free gingiva. Okay, and what those do is they support that collar of tissue, that free gingiva around our tooth, from just flopping over. Okay, so think of just like purse strings, keeping it nice and tight around the collar of the tooth. And those are our circular fibers. It's so nice that they name all of these somewhat similar, right? All right. Very good, you guys. So what do you think happens if bacteria gets into this free gingiva? Let me scroll up a little here. Okay, what do you think is going to happen if bacteria gets in right here? Why do you think it's important to keep that free gingiva nice and clean?
Because it would be hard to brush your teeth.
Okay, hard to brush our teeth. What else?
Starts getting retracted, starts getting infected.
It would get infected, and that's when it becomes gingivitis and or periodontal disease. Okay, do you guys remember what structure is found right here? What's this called?
The CEJ.
CEJ.
So that's on the enamel. Let me move it a little closer.
Dentogingival junction.
Right here. It's actually the junctional epithelium. Okay, and what we're concerned about is keeping that junctional epithelium right near the CEJ. Okay. What happens is in disease, the JE, the junctional epithelium, migrates apically. There's only one C there. All right. So Can I erase this?
Oh, wait.
Okay.
Okay, I'm okay.
Okay. So now what's happening is it's moving, oops, it's moving this way. That's what migrating apically means. Okay, so that's when the junctional epithelium, so what's going to happen is this attachment, this junctional epithelium in health stays near the CEJ. But what happens in disease, if bacteria gets in there, it's going to start to destroy that junctional epithelium, thus destroying the bone and the periodontal ligament. And that is when we have periodontal disease. So what happens first is this gingiva inflames, trying to fight it. And if it goes unchecked, then it starts to destroy that junctional epithelium, that attachment. And that's why it's important for us to know all these fibers. Once there's permanent destruction, which we usually will see here on the bone, okay? Once there's destruction, it is forever periodontal disease. That patient forever will have periodontal disease because we can't get that bone back. Okay? All right. I think that about wraps it up. Let me clear these drawings. Does anybody have questions on what we talked about today?
I have one question.
Please.
The circular fibers, are they the same as the gingival fibers?
Yes. They are one group of gingival fibers. I think they're the only ones we'll be talking about at this point. Okay, so they are in the free gingiva, nice, holding that collar of tissue up. Okay. Any other questions regarding the material today? All right, so let's, don't forget that your worksheets are due tonight, okay? And I believe you guys have a test on June 1st. There's no class next week. I will hold, I remember my Thursday office hours are open, so if you have questions this Thursday or next Thursday, I'll send out a reminder for you guys to join in if you have any questions, okay? We can kind of review anything that is difficult, but your best bet is usually to review your worksheets and then the highlights that I have in my book, okay? Any other questions on how to study for quizzes in here? So reviewing the worksheets, all the worksheets should be open to you guys. Remember, if you think you got something right or wrong, you know, look at the score first to see that you actually did get credit for it. And if you still question it at that point, send me a message, okay? How's everybody doing? A lot of information today, wasn't there? You guys seem to be picking it up quite nicely, though. Okay. All right. If you have any other questions, please let me know. I'm going to let you guys go. And then those of you